Successful management of pediatric difficult airway, both anticipated and unanticipated, is facilitated by pre-procedure assessment, preparation and planning. Due to anatomical and physiological differences, the technique of mass ventilation, direct laryngoscopy and endotracheal intubation is relatively more difficult in children. In addition, the time available to accomplish these tasks is lesser in pediatric patients than in adults. Airway should be evaluated with an airway focus history of previous encounters in ICU and OT, physical evaluation of head, face, neck movements, mouth opening, thyromental distance, etc., presence of any syndromes like Pierre-Robin syndrome, Treacher-Collins syndrome, or of any congenital anomalies like Goldenhar syndrome, craniofacial dysmorphia, micrognathia, etc. Various screening tests are available like the Cormack-Lehan scale, Mallampati scoring system, and many more. Unfortunately, there is no single screening test or combination of tests that can be applied universally. Moreover, most of these tests have only 30% predictability for difficult airway. Therefore, the ultimate goal of any airway management is to identify the problematic airway and devise a management plan including rescue and alternative pathways, keeping in mind that every intubation is potentially difficult. The last case is of a 1-month-old preterm baby, less than 3 kg in weight. Baby had history of hypotonia and multiple episodes of aspiration and was posted for an urgent feeding gastrostomy. Baby on admission was restless, breathless and needed oxygen support. He had a large tongue and had some undiagnosed myopathy. Later, he was diagnosed to have Prader-Willi syndrome. IV access was secured, minimal standard monitoring was applied, child had pediatric nasal prongs with 2 liters per minute oxygen on flow with an oxygen saturation of 96 to 98%. Orogastric tube was in situ. Since the child had hypotonia and some underlying myopathy, plan was to intubate after the induction agent without an IV muscle relaxant. Also, in view of poor respiratory reserve, it was decided to continue the nasal oxygen flow at 2 liters per minute during intubation to allow oxygen insufflation. Operation theatre was kept warm to avoid hypothermia. Pediatric airway cart was prepared with different laryngoscope blades, masks, airways, endotracheal tube, stellate, bougie, and pediatric LMA and CMAC video laryngoscope was kept ready. Suction was checked and pressure was reduced to 30 to 40 centimeters of water. After pre-medication with IV glyco and medas, IV propofol was used for induction. Baby was ventilated with 100% oxygen in 2% sevoflurane. Then laryngoscopy was done with MAC 0 blade, as MAC blade helps in accommodating a large tongue. However, I was unable to visualize the epiglottis or the larynx in the first attempt. Hence, I decided to use a CMAC video laryngoscope as it gives a better and a magnified vision. On video laryngoscopy, the epiglottis was barely seen. It was obvious that the larynx was very anterior. As you can see in the image, the arrow points towards the tip of the epiglottis. After mass ventilation with 100% oxygen again, I decided to use the conventional laryngoscope one more time. Using gentle handling of the laryngoscope blade, I took the large tongue on the left side. With external laryngeal pressure and manipulation, I could see the epiglottis and the posterior part of the vocal cords. I requested my assistant to give pressure exactly as I wanted, and once I was happy with the vision, I quickly inserted the 3-number uncuffed endotracheal tube into the glottis. Holding the endotracheal tube securely at the angle of the mouth, the circuit was attached. Endotracheal tube placement was immediately confirmed with end-tidal CO2 waveform and bilateral chest movements and breath sounds on auscultation. Oxygen insufflation with pediatric nasal prongs during laryngoscopy helped as it improved oxygen reserves and gave enough time for intubation without any fall in the oxygen saturation. When encountered with a difficult pediatric airway, effective and successful management requires access to advanced airway equipment such as supraglottic airway to relieve upper airway obstruction, intubating LMA as a conduit to pass endotracheal tube, video laryngoscope for better and magnified vision, airway adjuncts like the pediatric size stylettes, gum elastic bougies, cricothyroidotomy set, high frequency nasal oxygen, surgical airway access kits, pediatric flexible fiber optic bronchoscope and intubating guides, etc. Difficult pediatric airway may present to us in 2 scenarios, anticipated or unanticipated difficult airway. In anticipated difficult airway, do not sedate or anesthetize unless you're in a center with expertise in managing difficult pediatric airway. Difficulty could be in mass ventilation, intubation, or in both. Critical factor here is to maintain unobstructed airway and maintain spontaneous ventilation. Difficult mask ventilation is more difficult to manage. Given the inability of the children to cooperate, the potential to use awake airway technique is limited. IV sedation with drugs like ketamine, dexmedetomidine, midazolam with minimal effects on respiratory drive can be used. Advanced airway techniques to secure the airway may include but are not limited to indirect videolaryngoscopy, fiber optic bronchoscope, endotracheal intubation, and endotracheal intubation using a supraglottic airway device. Unanticipated difficult pediatric airway could be difficult mask ventilation, which in pediatric patients is usually a result of dynamic airway obstruction, which could be supraglottic, glottic, or infraglottic. For supraglottic dynamic obstruction, optimize the position of the head, use a chin lift or jaw thrust, put a shoulder roll, use airway adjuncts like oral or nasal airway and supraglottic airway device. For glottic obstruction like laryngospasm, apply CPAP using bag mask ventilation, deepen the plane of anesthesia with IV propofol 1 to 2 mg per kg, and if unrelieved, the gold standard is to use IV muscle relaxant. IV succinylcholine 0.5 mg per kg can be used. For rare occasions of infraglottic obstructions, for example severe bronchospasm, IV epinephrine, IV bronchodilators like derifylin, steroids can be used. Rule out gastric distension, limiting the lung expansion. Pass a nasogastric tube and decompress the stomach. Always ask for additional help in difficult mask ventilation scenarios. In unanticipated difficult endotracheal intubation, it may occur despite a thorough preoperative assessment. As long as mask ventilation is feasible, various options to secure the airway can be utilized. Though, avoid multiple attempts of laryngoscopy, as with each attempt, risk of airway trauma increases. Continue nasal oxygen insufflation with prongs. Consider indirect laryngoscopy using either videolaryngoscope or fiber optic bronchoscope guided intubation. A supraglottic airway device can be used as a conduit, and a flexible fiber optic bronchoscope can be used as a guide to pass the endotracheal tube through a supraglottic airway device. Cannot intubate, cannot ventilate scenarios are rare but potentially fatal events in airway management in a child. Continue 100% high flow oxygen and call for expert help. The time available and ease of surgical airway intervention decreases as the age of the child decreases. Supraglottic airway devices can be used for upper airway obstruction. Once upper airway obstruction is ruled out, and despite of rescue attempts and alternative airway devices, the CVCI situation persists, then surgical help should be immediately requested for either rigid bronchoscopy or invasive airway access. When surgical expert help is unavailable, needle cricothyroidotomy may be the technique of choice. Skills with rescue airway techniques including indirect videolaryngoscopy, flexible fiber optic bronchoscopy, supraglottic airway assisted fiber optic bronchoscopy, and needle cricothyroidotomy should be acquired and maintained using training, simulation programs, or clinical practice in non-emergency scenarios. Thank you.